I am delighted to welcome Gabe Medley, who is Vice President of Risk Adjustment for Blue Cross Blue Shield of Michigan, Shravani Thadakura, who is Inovalon's Senior Director for Product, and Lalith Mehta, who is Inovalon's Vice President for Data Analytics. So with that, we will get started. And as the stand-in, they gave me the clicker. So this could go awry at any point. There's a lot going on. So changes everywhere. There's a tremendous amount of attention on risk adjustment in particular. Before the change in administration, we already saw OIG intensifying its focus and CMS intensifying its focus on RADV with the intent, of course, to extrapolate financial penalties. There's been a little bit of jumble in that intention in recent weeks. But the bottom line is OIG has put out information suggesting that 99% of the time when retrospective medical reviews are conducted and changes are made in supplemental data, those changes are additions, not deletions, okay? So that has raised considerable concern. At the same time, we have seen OIG make the statement that 1.7 million people in this country have diagnoses that have been abstracted from in-home assessments with no evidence elsewhere in the record, elsewhere in encounters, that the condition being identified in that in-home assessment is actually being managed, is actually being treated, is actually maybe significant for that patient's care. Lots of dollars involved in this. I suspect that Gabe might have some thoughts around these observations, and I would love to give you the opportunity to weigh in.
Yes, this is very, very timely discussion with all the audit stuff going on. By a show of hands, how many are in the RADV audit or OIG audit? Dang, we're the only ones? Jeez. All right, I'm not saying anything. I'm quiet now. I got nothing to say. I'm sorry.
All right, next slide. I've got the clicker.
No, it's if I'm not sure any of the payers. So we're pretty large payers. Some of the nationals are getting caught up in it, and there's a lot of reviews on like unlinked charts and things of that nature. And so, if we want to have a discussion on it, happy to do so. In terms of what we're talking about here, it talks about like the 99%. Percentage of charts, and it talks about like how we have to be accurate. I think there's a lot of things, and we've talked with like legal and outside counsel about different things. I can only share so much, but the thing about it is, I think there's a lot. Everyone asks me, "Are you worried? Are you worried about the audits?" And I'm not necessarily that, because I think with all the I'll say the drama around like coding accuracy and all that, like, CMS is already requiring us to be at 95%, and then they're saying like, well, if you're missing a percent, are you out of compliance, and are you going to get sanctioned and all that stuff? But if you look at the $98 million, I mean, I'm not sure how big your program is, but for some of the payers, like that's not a whole lot, and so it's kind of like, well, what's CMS really trying to do? And I think. Before I get myself in trouble, I would say that we have to look at it from a perspective of like underpayments. Because if you look at the industry now, like what's going on, and we're getting a lot of the payers are kind of caught up in the reimbursement is low, right? We're not getting paid enough, and then the medical cost is high, and then we're coming back and getting audited. So I think there's got to be a balance somewhere, and I think you're starting to see that with like the court cases and things that are coming out. So I think what we have to do is, I wouldn't say fight for your life, whatever, but something like that. But I think
your right to party.
Maybe,
I don't know.
Yeah. I think we have to make sure that, like, not only looking at the overpayments and stuff, but also looking at the underpayments. And I think that's where that's what we're hearing from our outside counsel. It's like, hey, look, don't sit there and take it. Also look at the underpayment components of it, because there are, even for both RADV and OIG, there's opportunity to do that. So I think that's where you can balance the scale here and make sure that you have coding, make sure your stuff is accurate, but also make sure you're looking at what's underfunded as well.
So there's been a great deal of change announced regarding how RADVs are going to be conducted. I'm sure everyone in this room is well aware of what these changes are. With significant expansion of RADV capability, expanding the pool of coders from around 40 to around 2,000 is what CMS has estimated. They've also announced that they're going to be utilizing, quote, advanced systems to identify diagnoses that they suspect are very likely to be unsubstantiated. To my knowledge, we haven't seen what those systems are, so I'm happy to have that elucidated if anyone has heard more than I. Expanding RADV audits from around 60 plans a year to everybody, to all eligible plans, and expanding the size of the audits from about 35 records to up to 200. So this is all very significant. And of course, the acceleration in catching up for 6 years of RADV audits that are a bit behind. The biggest news of late, of course, is that the financial penalty extrapolation methodology was struck down by federal court, and so that remains a bit up in the air. I think it's important for us all to recognize in this space that CMS has not remotely backed down from its intent to be stringent in upholding RADV rules and in holding us all accountable for the accuracy of the data that it's being submitted. This is a bump in the road for them, is basically what they've said, and they're going to be doubling down on making it work. Any thoughts on that, Gabe?
On this one, I think, so I was having a conversation earlier today, and you kind of hear, especially on the last panel, I was talking about like capacity and the providers and being able to, I think it's the same thing with the coding resources. We're all using them, right? Every payer needs them, even health systems. And so I think the resources are low. And so that's where I was like, my boss was asking me, hey, well, what do you think? And I was like, I think I don't see how they're gonna be able to do it. And then lo and behold, a few weeks later, this court case came out because I think there's just not enough capacity around. Now I'm not saying they're not going to do it, because we are getting audited, so that's a real thread. But I think when we look at the resources and the focus, I think it's the actual, I'll say, policy and around it. Like, we still have the extrapolation and all those different logic, and that it kind of ties in what I was saying earlier. Is that, you know, if we have these RADV audits going on, we want to make sure that we are looking at it across the board, the extrapolation logic, whatever that is. I think that has to be fair, because if it isn't, we're going to fight back. The one thing that we do have is we do have a strong legal. I think most health plans and stuff do, and we're going to have to make sure that we have a fair outcome from these. And there's so many different ways that you can I wouldn't say refute, but really push back on some of the things that are out. And so that's what I would just share with the group, is like, hey, if you're caught up in this and you are extrapolated against all that, there's still recourse to push back. And because there's just a lot of things that aren't necessarily appropriate with the extrapolation, and you're already seeing it. So
I think the bottom line is that, we've all in this room worked together to try to make sure our data are accurate, right? And that's not changing. The scrutiny is intensifying, and so the what hangs in the balance might be increasing, but we have to work together to make sure that the data we're submitting are in fact accurate. And it's incumbent on all of us to have good systems in place to make sure that we're identifying diagnoses that might be in question, that might be questionable, and also that the processes that we're using to make sure that our abstraction is accurate are in fact doing that, and are not simply pulling in additional diagnoses without scrutiny on accuracy of those additional diagnoses, and without scrutiny on the accuracy of diagnoses that have been submitted that might not have been substantiated. So we've got work to do. And with that, I think that Lalith is going to, and you just tell me when to click and I'll click.
All right. Thank you, Dr. Page. Thank you, Gabe, for bringing us to this point. And I would like to echo what Dr. Page said. although it is not clear what CMS is going to do, RADV rule-wise, right? It has always been clear that CMS wants health plans to be submitting accurate data. The accountability of data accuracy falls on the health plans. And from that perspective, it is imperative to put proper compliant programs in place that are looking and validating what is being submitted to CMS. And there are three main pillars in achieving a compliant program. What we always like to say is leverage the data and analytics. Like this, look at the patient's history, look at all of the data that is coming in, and evaluate the members, stratify the members, because not all HCCs are equal, not all HCCs are audited, not all members in the plan are audited. So stratify the members, look at the data, stratify the members not only for undercoded conditions or misdiagnosis, but also for overcoded conditions during the dates of service, because that gives the time to actually go and capture the conditions and get confirmation. Second one is the smart interventions. Historically, most of the health plans have approached RADV readiness as a retrospective chart review activity after the payment year has ended. Although very useful, it is more of a reactive approach, and it doesn't lend itself very well to what can be achieved as a proper compliant program. More and more health plans are now leveraging prospective outreaches. So they're running analytics more frequently during the dates of service and identifying the undercoded conditions as well as the missed conditions, as well as the overcoded conditions, stratifying them, and leveraging the opportunity of when the patient is visiting the physician, having the physician confirm the potentially overcoded condition as well, and either confirm or deny, and get it documented in and during the dates of service. And third, and finally, track and monitor the impact. It is very important to measure and close the loop on the outreaches that are being performed. And we can go to the next one. The data is changing every moment. Every time a patient visits a physician, every time a patient gets a prescription drug or visits a lab, there are data points generated, and these are data markers that can substantiate a condition or give insight into whether a patient's conditions are worsening. And I would emphasize that it is imperative for health plans to actually invest in robust health analytics that is looking at all of the data markers surrounding the members' data and identify what's going on with the member, stratify the member, recalibrate the risk regularly, and then put a compliant program in place. This way you can hone in on the members and the member conditions that are undercoded as well as overcoded, and try to put a more compliant program in place. So I was speaking about identifying the members and the conditions. Shravani, why don't you take us through some of the tools that are there that can help the review process itself be more efficient?
Definitely. Am I the only one freezing here? Because it's the cold if I'm playing with my hands. So thank you, Lalit. So we definitely need those efficient coding tools, because the importance of coding accuracy is the topmost priority, or I should say has been the topmost priority in response to rising costs, coding complexities, and increased scrutiny. Given how complex the medical records are to begin with structured and non-structured data, as well as the format itself being so different from one EMR system to another, makes the process even more complex. So definitely the health plans would need those efficient coding tools. Basically what they need is something for their coders to get their jobs done faster. Because I'm sure that every coder in this room or anyone from the coding team would attest to how long it takes to complete one chart review. Just imagine a coder going through 2,000 pages, 3,000 pages of chart to be able to document that active diagnosis of the patient. It is a painful process. I work with them every day. I don't want to get emotional, but they work hard. So definitely they need a tool with smarter condition recognition, which basically would be able to pinpoint and highlight those documented conditions for them, highlight those risk-adjustable conditions for them, basically, which will act as a guide in this entire process for the coders to save their time. This obviously means integration with new technologies. And every day we've been seeing how AI has been evolving. And I definitely think that the advancement in technology is definitely getting us there. But I would also think that human in the loop is still a complementary process in all of this to avoid compliance risks. Because at the end, our end goal is to work smarter without sacrificing accuracy. So, sorry, thank you for that. So talking about accuracy and precision, one other thing comes to my mind is that not only focusing on the well-documented conditions, but I also think the coding tool should basically be able to train and analyze the provider documentation, because that can also very well vary, because one provider can write another way. So this tool should also be able to analyze the terms and terminology, the documentation written inside the chart, be able to analyze the context around what the provider actually wrote in the chart, which basically would help tremendously. For example, if the tool would be able to identify the different sections in the chart, like past medical history, family history, patient education, consent, risks. There are many sections in a chart, if you ever saw that, like disclosures, and then risks and procedures, and any ambiguous statements also written as such as suggestive, probable, and also any negation statements written like rule out. For instance, here we have rule out COPD. So all of this, what I'm trying to say is, if the tool also focuses and trains on all such important aspects, it will tremendously help to reduce the false positives, less risk of overcoding, which Lalit has mentioned, and also basically helps and minimizes the risk during the RADV audit process. I'm sure, Dr. Killian, you might have gone through hundreds of audits now, and probably you had sleepless nights even. So would you be able to walk us through such real-world examples where you saw this kind of documentation on the charts?
Absolutely. You made a point that I want to emphasize. You said that these tools, that human in the loop should be complementary. I would go beyond and say it's essential. Human in the loop for medical record review at this point in time is still essential. We know that there is technology that is performing medical record reviews, and that there at times submissions are occurring based on diagnoses that are abstracted from technological reviews. We have seen some very concerning examples of diagnoses that absolutely should not have been submitted, but were because of the absence of a human in the loop. So we're up here emphasizing human in the loop. Maybe someday we'll get beyond that, but it's not today. So with that, I'm going to show you some highlighting of diagnoses that were identified. These are real examples, diagnoses that were highlighted by NLP and were submitted. And I'm going to see who in the audience can tell me why these diagnoses shouldn't have been. So in this case, atrial fibrillation was submitted. What's the problem? Yes. So, and this is one that burns me a little as a doctor, because we physicians document in a certain style. And, one of the things that we are very likely to do is say that, the patient presented with shortness of breath and palpitations, and on exam had an irregular rhythm and an EKG with an irregular rhythm, suggestive of or consistent with AFib. Here's what I mean. Patient's got AFib. That's what I mean. Patient's got AFib. But we add these, actually, that is just a stylistic thing that still is present. So as always, coding rules are not necessarily built around physician style of documentation. There's a mismatch. So absolutely, because suggestive of was used here, this would not be allowable according to coding rules, not allowable for risk adjustment. How about here? This BMI 42 looks very clear, well highlighted by an AI tool, submitted. What's the problem? So in this case, even though a BMI of 42 is risk adjustable, it is a secondary code. I cannot think of the word that I want to use. It is absolutely dependent on a primary diagnosis. So without a primary diagnostic statement that the patient has morbid obesity, that BMI of 42, even though it's absolutely clearly documented, no suggestive language, but cannot actually be captured on its own. So the problem here is the document source. So this diagnosis was made on an echocardiogram, which is not an allowable document at this point in time. It has been historically, it is not currently. And so even though it is actually a definitive way of making the diagnosis, until the physician makes a diagnostic statement of pulmonary hypertension, interpreting the echocardiogram outside of the echocardiogram, it's not allowable for submission. So what was highlighted here and submitted actually was diabetes with renal manifestations. Now, coding rules allow for some of the common complications of diabetes to be associated with the statement of diabetes without the physician specifically linking them, unless the physician attributes the potential complication to another cause. So in this case, diabetes with renal manifestations was identified for submission, but because the physician has attributed the nephropathy to HIV, that can't be done. So a human being still at this point in the loop would have prevented all of these errors. Problem here is that this is stated as past medical history of asthma. And so this is another mismatch in my so difficult to elicit opinion. Another mismatch between the way doctors document and the language that coding rules require. So when a patient comes in and I say she's got a past medical history of asthma, I mean, she's got asthma, but because it's stated as a past medical history, a coder has to interpret that as it's in the history, and unless I've said today that the patient has it and I'm treating her for it today, it cannot be captured. At least for ACA specifically. Medicare is still a little bit, still has some wiggle room there.
If you have the answer.
What's the problem here? Multiple sclerosis highlighted for submission. And you got it. So the spouse's medical conditions are not allowable, which I think is reasonable. I'm not even going to defend that. How about here? CVA is a stroke. Any guesses? Yes. So this is a patient who's being seen as an outpatient to follow up a stroke that occurred in the hospital. So it cannot be captured in the outpatient setting. Prostate, yep. And so there are kind of two problems here. So absolutely the historical piece. And keep in mind that cancer has very specific coding rules that exceed even those for other conditions. So even if the prostate cancer is being addressed today, unless it's being actively treated, or the patient is declining treatment for prostate cancer that is specified as active, it can't be captured. So surveillance doesn't cut it for cancer. Okay, so the bottom line is, I hope we've emphasized enough that human in the loop is really very important. With the tools that you might be using to streamline medical record review, it's also critical that we all work together to make sure that we're applying the analytics and the processes to ensure that data are accurate in our submissions. Gabe, do you have any comments on best practices for establishing an overarching program of conservative diagnosis submission of caution.
Be conservative? No.
Prudent caution.
Yeah, I think one thing that I wanted to call out, like we talked a lot about the coding, but one of the biggest challenges with the retrieval, I would say RADVs just in general, or just trying to get the right information, is to have the information. And so that's what we noticed on some of our audits, and then making sure we have those charts, those records. And sometimes, like, for instance, what we were showing the examples, you can't find it there, but if you had gotten another chart, you may have found the appropriate documentation. And one of the limitations is getting that information. And so digital retrieval is a really big deal. I know a lot of folks are looking at it or using it, but we've had a lot of struggles with getting pulled into like standard retrieval and not getting all the information from all the charts. So what we've done on RADV is actually pull all the charts that would for over and underpayment. So then you can, I would say conservative view is, hey, let's look at both sides. Hey, maybe past medical history, you can't qualify the condition, but you have an underpayment HCC. But if you hadn't gone after that underpayment chart in the first place, you may not have been able to offset it. So we're not trying to game the system. We're just trying to make sure we have we're getting the appropriate payments. And apparently we're underpaid because the trend is we're seeing higher costs than what the revenue's coming in. And we're still trying to get our, I know a lot of folks are looking at persistency rate, recapture rates, things like that. We're not there. We're not at 99%. So, the documentation is out there. So I'm just saying, go after it, get all the information, and then so you can have the best overall. And then you need systems like the Inovalon's tools, other vendor tools that are out there to help you go through that information really quickly, so then you can make a decision on what needs to go next. And then that will get you your best outcome on it. So.
Very well done. Thank you. Any questions?
Was the documentation something that you determined to be derived from a technical solution that was providing that documentation, or had a human created that entire chart? So
a human had created the chart. Technology was used to review the chart, and the recommended diagnoses for submission were highlighted.
Got it.
So that, I think, was atrial fibrillation in that example. So the technological solution was, the NLP said, submit this. And we have had experience with our health plan clients asking us to review records. This is, we do not do medical record review any longer, but when we did, asking us to review records for which a solution had recommended submission, or for which submission had in fact occurred and was being challenged. And so these are real examples of submitted diagnoses that came from a technological solution, but of human documentation, but no human in the loop for medical record review. Does that answer your question?
Perfect, thank you.
Okay.